Welcome to Unique Mentors Physiotherapy online classroom. Today, let's dive into part 1 of the neurology question answer sessions. Here, we are trying to crack the neurology questions using the key concepts, the challenges, and the best practices in neurological physical therapy. Question number 1. I'll read out the question first and the options also. You are evaluating a 65-year-old man who has suffered a recent stroke and related apraxia. He cannot brush his teeth on command. However, he can point out the toothbrush and verbalize the purpose of the brush. From this information, what sort of apraxia does this patient have? How should the physical therapist approach the treatment? Now, the options goes like this. Ideomotor apraxia, the physical therapist should speak in short, concise sentences. Ideational apraxia, physical therapist should give the patient 3-step command. Ideomotor apraxia, the physical therapist should always give the patient 3-step command. Ideational apraxia, the physical therapist should speak in short, concise sentence. So now, when you analyze this question, first of all, the age of the patient, 65-year-old man, okay? And now he had a recent stroke and the related apraxia. So he has got apraxia. Now we are giving a command to brush his teeth. We are giving him a toothbrush and asking him to brush his teeth, but he cannot do it upon command. But when you give the toothbrush, when you are pointing out the toothbrush, the patient can point out the toothbrush and tell how and why the toothbrush is being used. Okay, the purpose. He can explain the purpose of the toothbrush. So from this information, what sort of apraxia does the patient have and physical therapist approach for the treatment? This is the question. So now we have two types of apraxia. We have ideomotor apraxia and ideational apraxia, as you can see in the options. So ideomotor apraxia means the patient has the motor idea. I'm putting it in this way so that it will be more easy for you to remember. The patient has got the motor idea. So that means patient know how to do this. He knows the purpose of the tool that he is using. He know properly how to execute the activity. But the only thing is, because he has got apraxia, he is not understanding your command. So he will not do it upon command. You are asking him to brush the teeth with a toothbrush. You are giving a toothbrush. He is not understanding what you are saying, so he will not do it upon command. Okay. So we'll take another example. Suppose telephone is ringing. So you are asking him to pick up the telephone. He is not listening to that. He is not doing that because he is not understanding your command. But he is left over alone and the telephone is ringing. Spontaneously, he will go and pick up the telephone and will speak. So he knows how to pick up the telephone, how to use the telephone, but he is not doing it upon command. This is what you call as the ideomotor apraxia. Whereas ideational goes in a different way. There, the patient cannot do the activity either upon command, neither upon command, nor spontaneously he is able to do the activity. Okay, so he is not able to do the activity in any way. He does not have the idea on how to do that. He cannot use the tool properly. Okay, so if you give the toothbrush, he is not understanding for what the toothbrush is. Okay, he doesn't know the purpose of the toothbrush. Okay, and one more thing that you can see in ideational apraxia is he will not have an order of doing the things. So he will first put the shoe and then try to put the socks. So this is another feature that you can see in ideational apraxia. Now coming back to this question, here you can see that the patient is not brushing his teeth upon command, but he can point out to the toothbrush and verbalize the purpose of the toothbrush. So he knows for what it is being used. So from this explanation, it is very clear that your answer will be ideomotor apraxia. Now you have two options here. You have option A and option C with ideomotor apraxia. Now let us see what kind of management you need to give them on this. So here you have what kind of management you need to give for these patients. So you can give 3-step commands, or you can speak in short, concise sentence. So option A is short, concise sentence. Option C is 3-step command. 3-step command means first the therapist will be demonstrating the activity. Then he will be asking the patient to imitate the activity and then repeat the activity. This is called 3-step command. So this 3-step command is required only when the patient does not have any idea on the purpose of the tool or how to do the activity. He doesn't know anything on that. Then you have to use this 3-step command. So here we don't require a 3-step command because the patient is having an ideomotor apraxia. Okay. So your answer will be option A, ideomotor apraxia, and the therapist should speak in short, concise sentence. Now moving on to question number 2. A patient who has suffered a cutting injury to the entire left half of the spinal cord at the T8 level is being examined by the physical therapist. Which of the following impairments would be most apparent on the ipsilateral lower extremity? The options goes like this: loss of pain and temperature sensation, loss of movement and light touch sensation, loss of peripheral smooth muscle control, and loss of coordination and accuracy. So now here what you have to see is, first of all, when you are getting any question related to the spinal cord, you have to see which level it is. Of course, this is T8 level. He had a cutting injury, and the question is asking for the most apparent loss or impairment on which side. That is also very important, on the ipsilateral side. So these are the key points that you have to check with in this question. Okay. Now we'll go on to the answers. Option A is loss of pain and temperature sensation. Pain, temperature sensation, as you know, it is carried by spinothalamic tract. And this spinothalamic tract usually crosses in the or at the spinal level itself. Okay. It crosses at the spinal cord itself. So once it is starting and immediately it is crossing. So when you have a loss on one side or you have a cut on one side of the spinal cord, definitely the contralateral side spinothalamic tract will be cut. Okay. The contralateral side spinothalamic tract will be cut. So the loss of pain and temperature sensation on the contralateral side only will be lost. It will not be on the ipsilateral side. Okay. So it is a contralateral loss of the pain and temperature sensation. Okay. The reason being the tract crosses immediately at the spinal level itself. Now, second one is loss of movement and light touch sensation. Now, this is a function done by the proprioceptors, the joint receptors, and the tract that is carrying this sensation is fasciculus gracilis and fasciculus cuneatus, which is crossing at the brain stem. It is not crossing at the spinal level. Keep this in mind. Okay. Now, coming to the option C, loss of peripheral smooth muscle control. Okay, so that is option C. And this is not having any, it's not related to the spinal cut. It is all related to the adrenergic receptors. It is totally dependent on the adrenergic receptors. Okay. Now, loss of coordination and accuracy, which is dependent on the cerebellum. So this usually goes off when you have a cerebellar lesion. So what will be our answer? Our answer will be option B, because loss of movement and light touch, which is carried by fasciculus gracilis and cuneatus, which is traveling all the way through the spinal cord on the same side itself, and then it will be crossing to the opposite side at the brain stem only. So when you have a cut for the entire left half of the spinal cord at the T8 level, the patient will have loss of movement and light touch sensation, which is carried by fasciculus gracilis and cuneatus, and that loss will be in the ipsilateral lower extremity itself. So your answer is loss of movement and light touch sensation. Question number 3. The physical therapist attempts to improve a patient's lower extremity strength. So we can see that it's strength to improve the strength. That is the purpose. Which PNF technique would be the most appropriate to achieve the therapist goal? The options goes like this: contract, relax, repeated contractions, rhythmic stabilization, and hold, relax technique. Okay, so we have several PNF techniques designed for specific purposes. Okay, now let us see what each of this is meant for. Contract, relax usually is meant to increase the range of motion. Here we are using isotonic contraction of the antagonist muscle. So we will be giving isotonic contraction in a peculiar way. We will be giving, I am not going into the details. We are giving isotonic contraction to the antagonist muscle, and when we are giving isotonic contractions to the antagonist muscle, the agonist muscle will relax, and we will be pushing the limb into the agonist direction, which will help us to gain more range in the agonist direction. Okay, so mainly contract, relax is meant for increasing the range of motion. Okay. Now coming to repeated contractions. Now here we are giving, initially we will give a quick stretch followed by isometric contraction and isotonic contraction. Okay. So now this particular contraction or this particular technique is usually used to initiate, both to initiate and to sustain a contraction. Okay, so we are initiating a contraction, and along with that we are trying to sustain that contraction for a longer time. Okay, and definitely that will help in increasing the strength. Okay, so we'll give a quick stretch, and then we'll give an isometric contraction to the muscle, and then an isotonic contraction to the muscle. Okay, now coming to rhythmic stabilization, this is meant for increasing the coordination, mainly the coordination. So it also increases the range of motion. Okay, so range of motion, and for coordination we are using rhythmic stabilization. Now coming to hold, relax, again it is the similar as contract, relax. The only difference is in contract, relax we are using isotonic contractions of the antagonist muscle to increase the range of motion. Here we are using isometric contraction of the range limiting antagonist. Okay, so when you give isometric contraction to the range limiting antagonist, the agonist will contract. Okay, and agonist will relax. Okay, now agonist will relax, and you are pushing the limb into the agonist direction. Okay, so that will increase the range of motion in the agonist direction. We are giving isometric contraction to the antagonist. Okay, reciprocal inhibition, that is the physiology behind contract, relax and hold, relax. Okay, so now coming back to all our options, which is our right answer? Okay, see, our right answer will be repeated contractions, because it helps both in initiating the contraction and also in sustaining the contraction. I am repeating the technique once again. We are giving quick stretch followed by isometric, then isotonic to the agonist muscle. Okay, so that will help in improving the strength. Thank you.